First of all, I'm obviously a medical doctor. I'm going to talk about my health institution here. But as a medical doctor, you're medical professionals, I have to start with my conflicts of interest slide. I have just a few. Suffice it to say, I've started a bunch of companies, I consult for a bunch of companies. I wouldn't blame me if you didn't believe another word I said over the next 20, 25 minutes. But I'm really proud of the right column there. Those are the companies started by my students, my grad students. More than half my grad students start companies, even if they go into academia, and they do it with the most amazing platform in the world. It's often data, it's big data, it's often public big data. I'm going to show you how they do it. I'm going to show you how we do it at the University of California, and maybe I'll convince you it's an amazing time to be thinking about not just what you sell, not just what you buy, you get people to buy, but what is the data behind all of that and how that inspires innovation. Obviously, data is everywhere. You can't help but pick up a cover of a magazine, you see something like this, whether it's any scientific journal or lay journal, data, big data, AI are all obviously top of mind. In fact, The Economist covers it again and again. You can see at the bottom there, starting with the data deluge. And then on the right, it says that data, it suggests that data is the world's most valuable resource. And how do they show that? They show oil rigs. And this is a common phrase, right? Data is the new oil. And if data is the new oil, AI is the new engine, they say. I hate this phrase. I hate this phrase. Because as we know, especially in California, with oil is grabby. Either I have that barrel of oil or you have that barrel of oil. We can't both have the same barrel of oil. Data doesn't work that way. I might have a data set and create something magical with that. You might have that same data set and create something differently magical with that, right? So as another one of those TED Talks says, data is the new soil, right? You plant your ideas in, data helps them grow. So I like that phrase. It's a little bit more nurturing. And certainly we have a lot of data in biomedicine. Now, one big data set I'm going to be talking about here are electronic health records. You've already heard about them most of the morning here, but boy, are these expensive. Here are just some price tags. At the back there, Sutter, which is a major health system, network of health systems in California, spent $1 billion on their EHR. Partners, which used to be Mass General and Brigham and Women's, and their 40 or so affiliates, spent $1.2 billion on their EHR. And then Kaiser spent $4 billion on their EHR. And amazingly, they all bought the same system, Epic. Okay, so the price tag ranges from $1 to $4 billion. And so, of course, it's not just the software, it's train the trainer, it's sending all those folks to Wisconsin to then come back and know how to train your own folks and all the badges and all of that. But it's a costly effort. So the narrative, if you remember nothing else from this talk, the narrative I want to make sure that you get is what a national tragedy it will be, given the hundreds of billions of dollars we spend on these systems. What a national tragedy it will be if we don't use this data to improve the practice of medicine, okay? And on average, the average byte of data in these systems is never used again. Now, of course, we have to do it safely, responsibly, respectfully. But what a tragedy it will be if we don't actually use this data to improve the practice of medicine. And with that, let me just talk about what we're doing with our EHR data. And with that, I'll just reintroduce the University of California. We are massive, 10 campuses, 3 national labs, but 200,000 employees, 250,000 students per year. It's about 10% of all US scientific productivity has the University of California author on it, of all science papers in all fields. And then within that, we have this new umbrella called UC Health. We have 20 health professional schools, of which 6 are medical schools. And then we have pharmacy, veterinary, dental, public health, nursing. We train half the medical students and residents in California, so even if they don't stay with us, we do have some influence on how they learn to practice medicine. About $2 billion in NIH funding per year, and we make about $16.5 billion a year seeing patients. So that places us as number 8 now in terms of nonprofit health systems in America. 5,000 doctors get a paycheck from us every month. About 100,000 doctors write orders on our patients every year. That's all the residents and fellows. 12,000 of the best nurses in America. And we're not just shoddy places. UCSF and UCLA are in the top 10 and getting better because others are leaving the US News and top 10. So just sitting still, we get to move up. We might leave too someday, but not yet. We have 5 NCI comprehensive cancer centers, 5 of these clinical translational science awards. And then we have these secret superpowers that are so secret, we even forget we have them. One is IRB reliance, which means if any one of our medical schools approves an IRB, the others automatically approve it. And centralized contracting. So if the Office of the President at UC signs a contract, all 10 campuses automatically agree, no renegotiation needed. These are two key components for scaling developments in biomedicine, right? We can scale like crazy. And now we have this umbrella called UC Health. This umbrella exists over the health systems. We have 12 hospitals as part of that, 4 more that we're acquiring in the next 2 or 3 months. And it exists for 2 reasons. So we can leverage our scale for value. So we actually use this enterprise to buy things together. I think something Medicare is just learning how to do, but we can buy hip joints together, knee joints together, one purchase order, and then to build a single accountable care organization for the University of California. That's an aspirational goal for us someday. But because we had to put this data together and figure out whose way of medicine are we going to practice? Are we going to go the UCLA way or the UCSF way? We had to put all that data together. And that's what this icon looks like. Those are the medical centers, UCSF, UCLA, Irvine, Davis, San Diego, and Riverside. Riverside's the tiniest. They don't even have a hospital yet. They're just a brand new medical school. UCSF and UCLA are the big gorillas, and everyone else is in between there. This is a busy slide, but it just shows this is proof that it's actually there. So you see the logos on the right there. And this is as of 2 weeks ago. So we have about 11 and a half years of longitudinal data, 9.1 million patients. So this is every dose, every drug, every vital sign, every pain score, every respiratory rate, every lab test result for more than 9 million patients going back 11 years. You can see some of the numbers there, about 500 million encounters, 1.15 billion procedures. That's everything from a Whipple surgery to inserting an IV, 1.5 billion medication orders and prescriptions, almost 50 million device uses. You can see some of the others there, 1.3 billion diagnosis codes, and sprinkled in the whole mix are 36,000 cancer genomes too, perhaps relevant to this audience. The diversity of the world lives in California and is treated by the University of California. So it's a very diverse data set and patient cohort. We treat patients from the richest and poorest zip codes in California, certainly. All this is merged with a lot of external data sets. We use this data to feed 150 internal dashboards for treatment, quality, payment, save money. We don't need to use this med anymore. We don't need to use this diagnostic anymore. And then to reduce, and then study and reduce costly practice variation. And then we de-identify it all for research, comparative effectiveness studies, and to generate AI models, which I will talk about. The rest I won't talk about. Just to give you some ideas here, for example, with the cancer genomes in there, I think someone mentioned ALK mutations earlier. I can sit in the back of the room and just quickly see we have 1,360 patients with a cancer genome with the ALK mutation. 2,933 had an EGFR mutation, which is probably a little bit more relevant, but 11,819 had a P53 mutation. We can literally do this in any conference room with our dashboards. This is proof it's not claims data. Here are the 16.5 million neutrophil measurements, right? Probably on your devices, okay? What else is there to buy, right? I mean, so these are probably all just done on the standard cell diff counting, 16.5 ranges from 0 to 100, so it's like the percent. To make this even more relevant for Danaher, I looked up some in the numbers in the back. To make this relevant to Cepheid, the Expert BCR Able Ultra test we use 576 times. To make this relevant to Mammatome, we've used the Mammatome biopsy kit 40 times, not very many. And then HemoQ, which is the point of care testing, I think, there's probably some here. The hemoglobin one we've used 6,570 times. So we can literally count every single thing every one of you sell to us because we're great at billing for it in Epic, right? And so it's all counted. We have all the outcomes. We have all the care before and after, right? That is what this data set is. Now, a big use of clinical data is going to be to train AI, right? I'm not going to talk about all the amazing other things we're doing, but I'm focusing on AI here. And the FDA is really all over this, whether you love or hate them. I know there's love or hate relationships with FDA here, but I'm amazed they give us guidance like this, right? Guidance, AI, machine learning, software as a medical device. I love that they actually give us guidance like this. And indeed, this is not theoretical. So if you look now, at their website, you can see the two links there. The link on the left is the FDA one. 692 algorithms already approved by the FDA, okay? And this is as of 2 weeks ago. And they curate this now once a year. It used to be once a week. I think it's too busy for them. Of which 533 are just in radiology, okay? And so the link at the bottom right is run by the American College of Radiology. If you're thinking this is theoretical and in the future, it's here and now. These companies are selling these to us. We're trying to figure out how to evaluate them. Are they fair? Are they ethically sound? How do we even steward them after we've bought them, right? To make sure there's no algorithmic drift and all that. So we'll talk about that as we go on here. But this is here and real right now. Just to level set everyone in the room, so you go to lunch knowing what these terms are, let's just make sure we all know what these four phrases mean. Artificial intelligence is the general term. That means computers mimicking aspects of human intelligence. Cars driving by themselves, languages translating by themselves. Machine learning is our way of teaching computers that using data. Now you might think about that and say, how else would you do it without showing the computer data? Well, in the old days, in the 70s and 80s, the past AI revolution, we didn't have a lot of data, so we would use rules. And we go to a doctor and say, what do you do if you see this? And what do you do if you see that? It turns out it's not a great, efficient way to teach computers. It's much better to see what they ordered instead of asking what they think they're ordering, right? And that's in the data versus the rules. Now, within machine learning, we have supervised and unsupervised. Supervised means we have a right answer. We want to get back that right answer. You can measure accuracy, sensitivity, specificity, ROC curves. Unsupervised means I have a mess of data. Just make it make sense for me. Put it in clusters and things like that. Deep learning is one kind of machine learning where the models look like regression equations point to other regression equations, kind of look like the human brain layers at one point. And large language models are one kind of deep learning, really specialized in language, as you know. Just quick show of hands, how many of you have actually played with a GPT? Any GPT here? So it's about, let's say, 70% audience. That's great. I think they announced yesterday 100 million people use it per week now at this point. So I'm glad this audience does too. Now, all of this sounds magical and mystical. These are just software tools you download off the internet to add to your software. Or to put it another way, there are dummies books you can buy for all of these subjects here. $17 each on Amazon Prime that comes the next day. So it's nothing more sophisticated. There's no wizard behind a curtain. These are just software tools that you buy, you can put into your software. And it's really great because a lot of high school kids know how to play with this stuff now. You can hire them as summer interns. They teach the rest of your team, sometimes better than Coursera videos. So it's an amazing time that we have a lot of students and people playing with all this. But boy, what a frenzy there is in this field in biomedicine. These are just some of the 3 press releases just in the past 3 or 4 months. We have Hippocratic AI trying to get to all the text data. And I'm going to keep focusing on text because most of our clinical care is documented in text. I know we love the structured data. I showed you a graph of the neutrophil counts, but the meat of what we do is actually captured in the text. So Hippocratic AI raises $50 million as a seed round, not even Series A. University of Florida announced a $70 million partnership with NVIDIA. And then another interesting press release, the scientists behind IBM Watson has raised $60 million for their AI startup. I didn't think they could ever do anything ever again after IBM Watson. I guess they're back. So there's more money, then who knows. 2 more new ones. Microsoft has a $13 billion bet on OpenAI, of course, commercial partner. Amazon now is investing in Anthropic. I think they're putting in 2 or 3 billion, 4 billion, sorry, I was off by a billion. You can see the frenzy in the space, and that's the investment that's going in right now. It's already there for biomedicine and in Epic. So Epic's already working with OpenAI to do inbox messaging, right? So this is the bane of physicians right now. It's what we call pajama time. All the notes might be done at home, and now you still have to respond to inbox messaging. Can GPT craft that response back? It's already in research tools. We already have centers like UC San Diego testing these in randomized controlled trials. Those RCTs are already done, and the papers are coming out in JAMA pretty soon. Okay, so like if you keep thinking it's the future, it is now. It's already been happening this year. Okay, that's how fast this field has been moving. Now let's talk about understanding and thinking about progress notes. One of the things we have at UCSF is we've legally de-identified all 140 million of our progress notes and dietary notes and nutrition notes and discharge notes, respiratory tech notes. We've just de-identified them all. We got them externally blessed. It's legally certified, so we can play legally with OpenAI. This is one example of that. This is a complicated cancer progress note. And this is what they look like if you remove all the new spaces and the lines and things like that. And the prompt at the bottom, which you can't see, is tell me about all the cancer biomarkers in this mess. And this was interesting because it says, okay, the cancer biomarkers in this patient, it's read the note, off the shelf GPT. There's ER, and it kindly tells me it's estrogen receptor. And then there's PR, and there's progesterone receptor. There's HER2, which is human epidermal growth factor receptor 2, right, HER2. And then it says mammaprint, MP, mammaprint, right? And so there's a little MP there, high risk. And why that's interesting is because our own oncology folks were missing that one, right? They didn't realize MP in that context meant mammaprint. It doesn't spell it out anywhere. And off-the-shelf GPT can now understand components of a progress note maybe better than some of our docs, okay? That's off the shelf. Well, yeah, well, let's put it into a table form. Okay, now mix it up with all the dates and all the other images, right? It'll generate tables for you. Patient summarization aspects here might be amazing with GPT, right? We got to explore those. We are exploring those, how to get that patient summarization. How would you treat such a patient? Well, on the top left, it says there's targeted therapeutics. There might be radiotherapy. There might be conventional chemotherapy. But what about before 2012 or 2013? Well, you didn't have targeted therapeutics. You would have to go this way or that way, right? So it knows the different treatment options depending on the year of what that you're thinking about. But are we that far away from how would I treat this patient? Imagine this prompt. How would I treat this patient if I'm really trying to avoid this side effect, which this patient really doesn't want, right? How would I treat this patient if I were superstar doctors Eric Topol or Bob Wachter at UCSF, right? We know them, we follow them on Twitter. How would they treat this patient, right? Because maybe I can just get to their records and learn from them. How would I treat this patient if I were Memorial Sloan Kettering, that whole center versus my center, right? How would I treat this patient if I were United Health? How would they want me to treat this patient, right? Are we that far away from this? Absolutely not, because it reads all the public coverage determinations and all of this, right? And we haven't even begun to fine-tune any of these things yet. Now, another amazing aspect I want to make sure everyone knows too is, remember, we give data back to patients, okay? We give data back to patients. One example of that is if you have an iPhone, which I'm guessing most of you do, you can actually click on the bottom right. You can go to the Heart app. It looks like Apple Health. It's called Health. It has this big heart on it. And you think it just tracks your sleep and your steps. But actually, if you click on the right icon and then click on Add Records, it will zoop all your medical records from whatever centers you go get care at. And in fact, if you get care at 5 centers, it puts them in timeline order automagically. And it's just using the user ID and password that your health center is giving you for their health portal, right? You might use the MyChart app. And Apple says they don't save this data. I believe them. But it's amazing to get it all in one place, right? I might get care at 3 different places. And all the blood tests are there. In fact, all the notes are there. All the patient notes are there too. And by the way, we do this not out of the goodness of our heart. We do this because it's federal law at this point, right? We have HIPAA, which makes sure patients have to get there, and 21st Century Cures, which makes sure that you get your notes too now. We're an open notes regime. If you don't see this and your health center isn't there, you should ask why, because it's federal law today for us to give you that data. But once you have that data, nothing stops you as a patient from playing with GPT as well. And that's what I'm going to end with here. Right, first of all, we already have apps. Now, Stanford wrote this app, and they took it down quickly. But you can actually get an app that just takes the data from the Apple Health part and your fitness and your sleep and just starts to create queries to GPT. How should I improve my sleep? How should I improve, what should I do next with my medical record? That's the killer question here, right? So we already have apps. I admit it's clunky. It takes privilege to know how to install the OpenAI app and copy and paste between these two things. I agree, it's privileged. But this is a green field today, patient-facing decision support, right? $2.99 to help me explain my echo, right? right? Or $9.99 to explain my cancer genome, right? Can we really even get to that? But I think we can. We have many patients now already starting to interpret and analyze their own data. The one on the back there is this mom. It was actually featured on the Today Show. That 17 doctors over 3 years could not figure out what their kid had. Said, to hell with them, I'm just typing in the symptoms into GPT. Boom, there's the diagnosis. And then went to the doc, said, yep, you're correct. Tethered cord syndrome for a kid. It turns out that all the doctors were missing. Now, look, again, it takes privilege to take that result and go to a doctor or to be a doctor to interpret it, right? There's going to be mistakes. There are these things called hallucinations. We could talk about that during the Q&A. But can you rely on AI to answer questions? Doctors versus GPT. It turns out if you look at responses to people asking questions on Reddit, the ones from GPT are more empathetic than the doctors answering questions. I don't know what that means about Reddit or why doctors are even on Reddit, but it turns out it answers with some empathy. I have a whole bunch of people to thank in the last few slides, all the collaborators over a 20-year career, all the folks in the UC system that make all this data move every 2 to 4 weeks centrally, and all the grants and all the institutes of NIH that have been funding me to do research. And I also have to thank my family at the bottom who lets me go all over the world to give talks like this. Thank you very much.